Welcome everyone to our 7th Healthcare Data Matters webinar, where healthcare leaders and innovators join in conversation to set a new standard of patient-centered and data-driven care. Today's topic will feature Dr. Nagy and Dr. Bergmann discussing how the team at Johns Hopkins leveraged their precision medicine platform to accelerate COVID-19 research and create a learning model for health systems. Before we meet our guests, let's do a little housekeeping. My name is Raj, and it's my privilege to be your host for this webinar. Let's start by covering a few disclosures. First, funding for the Healthcare Data Matters Forum is supported in part by Medical Informatics Corporation and Intel. Presenters' opinions and viewpoints are their own, and we do not pay speakers or offer any exchange for product endorsements. You can see other disclosures on this slide. Now it's my extreme pleasure to introduce our guests today. Dr. Nagy is an associate professor of radiology, the deputy director of the Johns Hopkins Technology Innovation Center, and the director of education in the Biomedical Informatics and Data Science Department at Johns Hopkins University. Dr. Bergmann is a T32 clinical research fellow in pediatric critical care at Johns Hopkins. Dr. Nagy, Dr. Bergmann, how are you doing today?
I'm doing great, thank you. Thanks for having us.
Great, doing great.
Thank you for being here. Our format today is first, I'll ask you some questions to give you the chance to present your work to our audience members. Audience members, if you have a question during the presentation, simply click on the Q&A button and type your question as shown on this slide. We'll address as many questions as we have time for at the end of the session. Sound good? Great, so let's get to today's topic. Dr. Nagy, let's start with you. First, I think it's pretty well known that Hopkins played a pivotal role in public health during COVID, but it is my understanding that your team also helped with clinical discoveries to support patient care. For example, I believe you created a COVID risk predictor. Can you tell us about that?
Absolutely. So we are not just a university, but a health system. And as we started seeing patients test positive for COVID and being admitted in distress, our director of our biocontainment unit, Dr. Brian Garibaldi, initiated a clinical registry with our institutional review board to start collecting all the clinical data we had on patients who are suffering from COVID-19 to try to understand better therapies for those patients and try to understand which patients would be getting sick. This actually became a large clinical registry at Johns Hopkins. We had over 200 clinical teams studying the data from different purposes. One of those projects was trying to look at patients as they were admitted to try to figure out how their change in trajectory could help us predict the rapid deceleration in certain patients and whether they would need ventilation services by looking at their change in oxygen saturation, supplemental oxygen, and other lab variables. And so this prediction tool was actually published, and we implemented this back into our EMR system.
Wow. And I understand that you did this within a couple of months. Is that true? And if so, how were you able to accomplish that?
So this was done, it took a real community. We have a large effort at Johns Hopkins. Johns Hopkins was founded to train physicians as scientists and to let them use their clinic as a laboratory. And today that's about helping them harness big data. And so the efforts that we went through is really 5 stages for the field of informatics, helping them collect all this data and catalog it, finding useful facts in that data that could feed data science prediction algorithms, and then turning algorithms into products that could be tested and validated with clinical users, that it creates value for the patients, it's integrated into their workflow, and lastly, we're studying it to ensure that it's creating value for patients as part of their care process.
Wow.
And this takes a large team.
Yeah, it seems
a lot
like
of different skills are needed to be able to go through each of those steps, from data science, library science, to implementation science.
Can you tell us a little bit more about the precision medicine platform?
Yeah, so we fortunately have been starting this about 4 years ago to help our clinical researchers conduct research for many chronic diseases and rare diseases. So we have basically are using a cloud infrastructure and a secure environment for collecting all the data from our medical records, our medical imaging, as well as our telemetry coming off of our beds and genetic sequencing. So this is a lot of really important clinical data that can create features that can help us predict which subgroups of patients might have different response to disease. And so this is a large cloud platform that includes not just data collection, but also a whole suite of analytics environments to help them create predictive analytics tools. And one of the main reasons for this platform is data gravity. So we have over 2.4 million patients and over 700 million encounters. Over 80 million medical images are performed on these patients. We have telemetry coming from 2,500 beds. So the data can be large. It's in often terabytes to hundreds of terabytes. And it can be very expensive to replicate and synchronize. But also, more importantly, their privacy is really a key risk thing. We want to make sure we really have minimized any risk around the data and making sure it's identified. And so all the analysis is done on the platform as opposed to being able to share the data with researchers. And so this researchers actually come onto the platform where we have all of their analytics tools. And this also brings the data closer to the network fabric where we can provide these computational resources on the data. So this is really a centralization in clinical research infrastructure, similar to how we've seen clinical information systems evolve over the past 15 years.
You mentioned that you could take this huge data set and start sort of bucketing or grouping patients. Can you talk a little bit about that?
So so within weeks of getting our IRB, we started turning on all the data we're seeing on these patients, all the laboratory tests, the vitals that we're seeing on the patients, all the medications that we're ordering on the patients. And so within a matter of weeks, we were able to publish our first results, trying to characterize which patients we wanted to know, whether patients were admitted from nursing homes, with patients based on their body mass index, based upon their gender, and of course their age, how they are responding, and who was getting sicker and how people are responding. That was really a major challenge, is trying to predict which patients are going to be needing more severe intensive services for their care.
That's very cool. And so with this huge data set, from all these different sort of systems, how do you sort of standardize on formats? How do you, make it so that researchers can use it?
So there's these electronic medical records are proprietary vendor-based systems, and they have proprietary data models. There's a large initiative called the Observational Health Data Science and Informatics Initiative, which has a common data model called OMOP. And so we actually led a national initiative last year called the National COVID Consortium, led by Dr. Chris Shute and Melissa Handel, where we actually converted 60 different health systems EMR data over into this OMOP data model, and then be able to combine it in a way that we could actually look for a larger sample size. And when you're looking for rare reactions or different types of responses, you really want to aggregate data from multiple sources for predicting algorithms. So it's really a question of how we can put that data into a standardized format. And this moves all the data into standard clinical terminologies, like lab tests should be in a LOINC measurement, diagnosis codes, and medications are also standardized so that we can have it down to the ingredient level. And so this really puts us in a nice observational framework for creating reproducible research.
Yeah. Did you say 60 different EMRs?
60 different health systems, from community health systems, from 60. So it was really fascinating point where we created this was a national initiative where the data was collected from these 60 different sites, and they signed a data use agreement where the collaborative could then study this. What was really also exciting about the N3C was that this was an open science environment where we had even amateur citizens. Now, no researcher had actual row-level data access, but as groups, they put together different queries and questions, and then the analysts behind the scenes can run those questions and return to those. So it's really been highly productive. It was over 1,200 different investigators involved in the N3C, and many different, and over 2.4 million patients, positive patients, in this data source. So it's really been a very effective way for looking for larger patterns. That's what we're trying to figure out. You need to to find subsets, you need to have a large amount of data, which is kind of the returning story of the big data science world.
Yeah. Yeah, especially with events that are hopefully rare, right? In the
And we're seeing that now
medicine.
for potential reactions for vaccines.
Oh, indeed, indeed. Yeah, so this is great, right? It's pretty clear that PMAP is very useful within the Hopkins system, but then how adding other institutional data can enhance this platform for even larger discoveries and insights.
Yeah, I think it's really important. I think we're entering the phase where the data will stay within the legal entity like Johns Hopkins or another health system. But what we can do with the common data models, we can actually share the code. Instead of sharing the data, we can pass the analysis back and forth, and that allows us to aggregate the results without putting any patient data at risk.
Now, it's my understanding that you're also beginning to integrate higher frequency data into PMAP. Dr. Bergmann is leveraging that data for remote monitoring, but for predictive model building. Dr. Bergmann, can you provide us with a general overview on the value of adding this high frequency data and maybe why it's been hard to capture in the past?
Yeah, Raj, I'd love to. Let me just start. I think most people are familiar with the challenge we have in the ICU. It's similar to the challenge all over the hospital, just sort of in more in a sense. We have lots of data for complex patients, and we're trying to make complex decisions. Just when we look at the EMR data alone, and at the same time, we're trying to learn from this process and generate new evidence so we can treat the future patients with that knowledge. We've also leveraged the precision medicine platform in the ICU. We've created a registry for anesthesia in ICU patients. We think that high frequency data can play an important role here, in the OR and the ICU. The dynamic response of patients, I think, gives important insight into the patient's underlying physiologic state. At the same time, it's traditionally been hard to really capture and look at all of that physiologic data. People sometimes call it ephemeral data. If you're not in the room looking at the monitor when that data goes by, then it's either hard or impossible to go back and get to that. But that's one of the things that we're really excited about doing is integrating that high frequency data into the rest of the precision medicine platforms data that's being collected.
Yeah, sure. Capturing the ephemeral data. Can you give us a bit of insight into the difference between this high frequency data and what might be in the EMR?
Right. The EMR traditionally represents validated data. So the nurses, the respiratory therapists, the other providers that are taking care of a patient will enter data into the EMR. Some of this is vital sign data, measurements from devices such as the ventilators and other devices. And the benefit of this is that it's validated. They look at that data. If the number doesn't make sense, they query the device and figure out what's going on, and they enter that data. But the challenge is that typically that data is recorded infrequently. For things like the ventilator, we might record data every 6 to 8 hours. And so that misses sort of large periods of time in terms of the patient's dynamic behavior. And then sometimes, despite everyone's effort, data does get entered that may not be correct. And so the high frequency data gives us insight into both of those issues. It gives us the ability to look at the kind of the dynamics of the patient and sort of see, how their heart rate's varying and, how their mean airway pressure is varying in a way that sort of just having a measurement every 8 hours doesn't give us. And then also when the patient does when the numbers do look weird, it gives us the ability to sort of dive down and get to the ground truth and understand if that number was because the patient was disconnected from the ventilator, or was it erroneously entered, or was something else going on? So I think the high frequency data really plays an important role in establishing the ground truth and understanding what's really going on with the patients.
Yeah, it makes sense. Adding granularity to your data can have a real impact on viewing the data itself. Can you provide some additional insight into how adding granularity can impact a predictive model?
Oh, yeah, that's, for example, in the ICU, we deliver oxygen to a lot of patients. Too little oxygen can definitely be problematic. But at the same time, there's a lot of data suggesting that too much oxygen can be problematic as well. When clinicians try to analyze or think about how much oxygen a patient's getting, it can be hard. The documentation in the EMR doesn't always reflect what's actually going on at the patient level. And so, this is another example where the high frequency data, gives clinicians the ability to really see and understand what's going on with the patient. And so here's just an example showing cases where, from the EMR standpoint, the patient was on a certain level, but in the room, the patient actually was getting a lot more oxygen. From a model building standpoint, these models are really only as good to a certain degree as the data we provide to them to train them. And so, providing the sort of most accurate representation of what the patient was receiving from an intervention standpoint is going to lead to better performing models. And then also when we apply those models to real patients, feeding them with what the patient is really seeing is also going to allow the model to make more informed and accurate predictions.
Yeah, that makes sense. Dr. Bergmann, Dr. Nagy, any key takeaways or closing thoughts from the work that you've been doing with PMAP and data collection and getting down to the granularity of things?
Well, I think we're really entering into the era of analytics in healthcare, and it's a really exciting time that EMRs really in the U.S. have been just adopted over the past 10 years. So now we've collected a lot of data. Now we're trying to learn from that data. So this is really the virtual cycle of a learning health system where we use our interaction with our patients and and as we collect data, we collect it with a perspective in mind for learning from that data so we can ask questions of it. So this is really our goal, is to start helping collect data on our patients that is tied to research that we can actually help benefit in their care. And so right now we know there's a lot of data being collected in a hospital, but there's even more data being collected by patients at home. And so having patients as partners in this process to help them manage diseases and share with them how to try to find predictions that could help them achieve better outcomes. This is really an exciting time as part of a learning health system where we can combine our clinical mission with our research mission to both deliver better care and to make biomedical discoveries.
I completely agree. And I would just add that, we have a responsibility to our patients to use the data that we collect on them while we care for them to, learn more about the diseases and processes that we're treating and to, roll that forward so that we can do a better job with each successive patient. And it's really an exciting time.
Yeah, that's really impressive work. And it makes a lot of sense, right? To learn a little bit more with every patient that you see and to be able to encode that learning and then share it across, share that expertise, right? Across an institution or even on the web, right? Or in the EMR. Absolutely. Makes a lot of sense.
I think what Dr. Nagy was saying too earlier, this, as we move to federated models, the algorithms, the things that we learn at Hopkins, the things that others learn at other institutions, being able to think about ways of sharing those algorithms so that we can, deliver better care throughout the health system, is also a challenge and I think a exciting area of development too.
Yeah, absolutely. That's very exciting. Very impressive work, Dr. Nagy and Dr. Bergmann. What you've been able to accomplish is going to advance the space of AI and healthcare as we know it. I would like to transition now to a Q&A portion so that we can make some space to answer questions from audience participants. As a reminder to those of you in the audience, simply click the Q&A button and type your question in the box. We are monitoring, so we will ask questions as they come up. I believe a couple have been coming up. Well, one question that's come up, and I think this is about PMAP. I know PMAP wasn't developed specifically for COVID-19, but it's certainly a good use case. Can you talk to other studies or algorithms that you've been able to start developing with this data set?
Yeah, one of the first algorithms we developed was actually for prostate active surveillance. And so a lot of times when adult men like me are diagnosed with a prostate cancer, it's often indolent, which means that it's going to be growing very slowly. And so the questions are, you have to weigh whether you want to have surgery or chemotherapy or radiation therapy. And so prostate active surveillance was studied over 1,500 men over 15 years, where they looked at their PSA levels, they did MRIs of their biopsies, and they tried to build, and they built this really fascinating Bayesian model for trying to predict underlying state of disease. And so this, what we ended up building this prediction tool, and we built an EMR integration process where the urologist can have a consult with the patient. This was led by Dr. Bell Carter and Ken Pienta. And it was really exciting where we did a randomized control trial where patients diagnosed with prostate cancer at an indolent level we actually did a randomized control trial where we offered them, we built this information visualization tool around trying to help them understand their disease and what patients like them will likely have in 5 or 10 years. And we studied its effect on our patients, and we found that it helped them in a couple major indices, such as the perceived control of your cancer, which is really, when you get a new diagnosis, it can be very overwhelming trying to understand how it's going to impact your life goals and your values. And so it helped them with their perceived control over their cancer. And also the other challenge patients have when you have a diagnosis for cancer is you're going to get overloaded with information. There's so many options, and it's very hard to wade through that. And this was able to help them with their information overload, which is also another important instrument in their care and their management. So this was really an exciting tool that we integrated directly into our EMR. It pulled data and it was able to share with them visualizations around what the underlying state is and what the probability of them having what's called a Gleason score upgrade in their biopsy if they do a biopsy in the next time period. So really help them be a more informed patient and partner with the urologist as part of managing their indolent cancer. Most of the time, or many cases, it's really not going to be the cause of mortality, and so it really gets into some of your values and some of the things that you want in terms of potential weighing the risk versus the benefits.
Yeah, very interesting and very different from COVID. So it's a useful data set.
But it's the same exact technology, whether it has a 20-year lifespan or really it happens really suddenly. Yeah. So it's really interesting how it's really about trying to collect data in a evidence-based methodology so that we can then really scrutinize it and study it.
A couple more questions coming through the chat. What has been your favorite aspect of seeing how the data is used at the bedside? I think it's probably for Dr. Bergmann. Yeah.
Oh yeah. At the bedside, I think for example, the ventilators is a great example. In this, played an important role in COVID and just in general life in the ICU. Traditionally our ventilators, they're in the patient's room. They're not connected devices. The only way to really see what's going on with the ventilator is to actually walk in the room and look at it. And, it's great to make people get into patient's room. I think it's an important, place for the providers to be, but it makes it just the barrier to seeing that data and sort of thinking about it and using it to make decisions about the patient's, managing the patient, it's just very large. And so as we connect these devices, as we get data off of these devices and make it available to providers sort of wherever they are, and then also make the ability to perform analytics on that data, that's really going to help us make better decisions at the bedside. So, it's kind of maybe ironic, the benefit is that it prevents us, it allows us to make decisions and understand the patients better without actually going into the bedside to look at the ventilator. But I think ultimately, having that data and being able to use it is going to play an important role.
Yeah, I would say it's fascinating if there's any budding data scientists out there. This is an area that's is very rife for innovation, and we're still in the very early stages of it, where if you go into an ICU, what you're going to notice, of course, is that there's a lot of alarms going off. And a lot of them are false alarms, whether it's coming from the ventilator, the infusion pumps. It's such an area of high technology, but relatively low integration, where that data is telling a whole story about how medications are affecting the ventilation of the patient. So there's often that data is coming in isolated from each other, and it's up to the care providers and nurses and the physicians to try to make sense of that story. And I think it becomes a lot of urgency And it's very easy it's much more easy to make errors that are important over urgent. And so you're seeing a lot of alarm fatigue, and yet you're trying to understand how the patient's responding, how you expect them to. So I think there's a great role for tools and inference engines to be looking at these data streams to be saying, I think there's something, that I want to draw your attention to without having to make it an alarm that has to draw their attention away.
Yeah, I think one nice thing about Hopkins too is you have a fantastic medical system and a great school in which data scientists can come and work on this data if they get access.
We do. We've actually, what's exciting is we've actually created training programs for teaching people how to use cloud computing, how to work with large databases of EMR data and do observational research with OMOP, and really take it forward to building these real-time decision support tools with the new FHIR interoperability training. So I think it is really important for us to create a new generation of software engineers and data scientists that understand and can be able to work with EMR data, which is really has a lot of interesting things where, we're not going to get uniformly sampled data because patients only come to a health system when they're sick. And so trying to look at it has lots of degrees of missingness that you have to evaluate for bias.
And we're really fortunate too, as Dr. Nagy was answering the question before about sort of threshold-based alarms generating a lot of false alarms and the benefit for fusing different data streams together. We have partners at the Applied Physics Laboratory, Johns Hopkins as well, that have a lot of experience in data fusion from other domains. And I think that's, and they've played a role in the precision medicine platform as well that I think has, been very valuable for us.
What a good resource. You mentioned that it takes a community, right?
It does. It takes, I think it takes IT professionals that can help deploy these systems. It takes software developers who could design them with user-centered designers who could make them usable for providers that's integrated into their clinical workflow. Physicians are incredibly busy. They're busier than they've ever been before, and they're being overwhelmed with information. So helping them really make sense of it and trying to understand how to take that and apply evidence to it is really, we're in the dawn of really creating a lot of effective evidence for how to treat disease. And so it's certainly a wonderful time to start seeing the impact of not just AI, but really just having advanced analytics that help people manage all this data when they're caring for the patients.
That is a good, that's a very good big picture view. And I think that makes a lot of sense. So zooming back in a little bit, we have a couple more questions in the chat. I want to make sure we get to them. But the question is about data acquisition. So you mentioned ephemeral data. How do you acquire ephemeral data from the ventilator? So settings and measurements, waveforms, things like that.
I mean, acquiring from the ventilator, most of the ventilators have a sort of a data acquisition port that gives you the ability to pull the data off. So, we actually work with medical informatics, and we work with other vendors previously that help us acquire that data. And so, and there's, it's not just one provider. There's literally, when you look at the chart connecting the sort of the device to how the data gets stored in a database, it's an amazing sort of HL7 messages, and there's something that broadcasts it to a bunch of different places, and someone has to capture that, interpret it, and they have to fuse data streams from ADT and from the device, and so it's actually a very kind of orchestrated, complex process. But yeah, I think that the bottom line is a lot of the devices have the ability to capture data that up until very recently we just haven't had the sort of capacity and ability to exploit or use.
For sure, right? Oh, yeah.
I mean, the data from the device is wonderful. The biggest challenge is making sure you're collecting the data, which patient you're collecting the data on. So often a lot of these devices are tied to a room. And so we'll know that data is streaming in from a room, and then we'd have to combine that with data from an EMR, which has all the transfer information of which patient was in which room at what time. And so you have to play a little bit of game on the background if you're not assigning it to the patient directly in the device itself.
Yeah, so clinicians, data scientists, hospital, IS, IT, and biomedical engineers, right? All playing a part in this pipeline. So We are at the end of our half hour. So let me thank you again, Dr. Nagy and Dr. Bergmann, for joining us today and sharing all this great information. A replay of this webinar will be available on healthcaredatamatters.com and a podcast version on our Health Data Matters podcast channel. While on the site, you can also check out our previous webinars and join the conversation on our associated social media channels. As we close this session, you'll see a short 5-question survey pop up. We would really appreciate you staying for 1 more minute to complete it. The survey really helps us to continually improve the content of the session and give us ideas for other topics you might be interested in. We will also be in touch with information on our next Healthcare Data Matters webinar. Thanks again for joining us today. Here at Healthcare Data Matters, we are grateful to have the opportunity to advance a new standard of patient-centered, data-driven care. Take care, everyone, and thank you to Dr. Nagy and Dr. Bergmann for their time today.
Thank you.
Thank you for having us.